Hello everyone, welcome to Human Diversity in Healthcare Week number 4, Disparities in Healthcare Access. The learning objectives for this week are risk factors lead to disparities in healthcare access. We also want you to be able to appreciate the unique needs and vulnerabilities experienced by select vulnerable groups, to be able to identify federal, state, and local agencies who serve vulnerable populations, and to be able to describe strategies implemented at the federal, state, and local level aimed at serving vulnerable and marginalized groups. And much of these objectives will be accomplished through the Wiki projects. Individual risk factors which lead to disparities in healthcare access are minority status, location of residency, socioeconomic status, as well as health insurance status. So if we look at minority status, we tend to find that through our readings and discussions in week 3, which carry over to this week, that those who are in minority racial and ethnic groups tend to have a higher incidence of lower socioeconomic status as well as lower rates of coverage of insurance. If we think about residency, if someone lives in inner city, there are both positives and negatives. The positive would be that they may be able to walk to a health clinic for access, but it also may mean that they live on the outer edges of the city, which means it could be a longer walk. If they live out in rural areas and they have a low socioeconomic status, they may have transportation issues. So when you go into the socioeconomic status, we also know that those who cannot afford to pay end up going to the emergency room. So again, where do most of the emergency rooms exist? More in cities or larger towns as opposed to in the outskirts or suburb areas. And if someone doesn't have health insurance, they have very limited access to resources. There are some clinics, but once again, the primary place for service is the emergency department. Did you know that the United States is actually the only developed nation that does not yet guarantee all of its citizens access to health care? But remember that that's through a system of universal health coverage. We are making strides with what everyone's referring to as Obamacare, but we still have issues to work through. In 2000, the World Health Organization released a report, and unfortunately the U.S. did not rank towards the top in two specific areas of focus. The first was we ranked 37th for health systems performance and 72nd in health outcomes performance, and that was out of 191 total. So there are failures to ensure access to uninsured, and low life expectancy are both contributors to these factors. In '65, President Lyndon Johnson enacted two major health insurance programs. The first being Medicaid, which is used for poorer populations, and then the second is Medicare, which primarily services elderly populations. I would like to show you a chart that compares Medicaid and Medicare. So the first factor here that we need to understand is that Medicaid and Medicare are both government-sponsored healthcare programs. Okay, but the programs differ in terms of how they are governed and funded, as well as who they cover. So you'll see here that Medicare is an insurance program, so it actually is an insurance program primarily used to cover seniors ages 65 and older, as well as disabled individuals who qualify for Social Security. And then Medicaid is actually an assistance program that covers low to no income families and individuals. So some may actually be eligible for both Medicaid and Medicare, and that depends on the circumstances. What we do know is that through the Affordable Care Act, or Obamacare, 26 states and the District of Columbia have recently expanded Medicaid, and thus more individuals have been able to enroll. And you'll also see below that there is a comparison chart which covers things like we just spoke about the overview of who they cover, eligibility requirements. So you'll see if we keep the header up here for the Medicaid, it says strict income requirements related to federal poverty levels. So with expansion under the Affordable Care Act, 26 states were able to cover at or below 138% of the federal poverty level. Over here for the Medicare, it says regardless of income, anyone turning 65 can enroll in Medicare. And then it says so long as they've paid into it throughout their life. So people of any age with severe disabilities, people of any age with severe disabilities and end-stage renal disease are also eligible under the Medicare program. Also talks about services that are covered, the cost to enroll. So if you want to just stop your slide for a minute, or actually the video for a minute, and take a look at several of these factors, it is kind of interesting reading through to see what the true qualifications, who governs the two different programs, and then of course, the populations that are covered. Then as we come back to our original slide, you'll see that in 1997, which really isn't that long ago, the federal government enacted a program for children and low-income families. Does anyone know what the name of that is? For Pennsylvania, that is referred to as the CHIP program. So here we have another website to show you a little information. So it's actually, the website is found at www.chipcoverspakids.com, and here's some of the information on the CHIP program. So what is the program? It's short for Children's Health Insurance Program. One of the key things here is that it does offer the eligibility for individuals who don't qualify for Medicaid, but at a low cost can cover their children under insurance, because they can't either afford a higher premium insurance, or maybe they do not have a higher premium insurance available to them. So once again, the CHIP program here is another subsidized program for low-income families. Here it says parents may think their children can't get CHIP because they make too much money, but that's not true. CHIP covers uninsured kids and teens up to the age of 19 who are not eligible for medical assistance. And once again, if you want to read through some of this information, it's certainly good to know for all of the different populations that we serve. Just a short 7 years ago, close to 15.4% of the population did not have health insurance coverage. It would be very nice if we could see those numbers reduced, and a dream would be for someday to actually have everyone covered. It's important to look at the characteristics of the uninsured population. We have spoken about over the course of several weeks different stereotypes or biases. So let's take a look at some of the statistics for uninsured populations. It says 3 in 4 live in households with at least one adult working full-time. 70% are white. 52% are at or below 138% of the federal poverty level. 40% are between 139 to 400% of the federal poverty level. The majority are between the ages 26 and 54, and more than 3/4 reside outside of the Allegheny and Philadelphia counties, which are two of our most populated areas in PA. Another interesting fact, 75% of Pennsylvania's uninsured live in households, like we said, with at least one working adult. So we're going to break it down and say the jobs the working uninsured hold are listed here. So 22% are in the area of trades. The next highest is the 17%. And it looks here, although these colors are a little confusing, they're in information and financing. So again, some interesting characteristics. Here, percentage of the uninsured individuals in a household with at least one working adult, broken down by counties. So the largest numbers are in the dark counties, and if you think about where the larger cities are and where the rural areas are, that could certainly play a role in this information. Then here we have another slide, Pennsylvania uninsured persons by race and ethnicity. And here, like we said initially, 70% are actually Caucasian or the white non-Latino race. If you look here at the next slide, individuals with income between 139 and 400% of the poverty level. The largest volume is actually the eastern and southern northeast to southeast portion of Lancaster County. So for those of you who live close by, that is the largest number. That's the area with the largest number. And then if you look here at those under the 138% of the poverty level, it's actually the same area we just discussed, but expanded slightly, and then a couple areas in central and eastern Pennsylvania. So there's more slides here, and I will include these separately in the module, but wanted you to be able to look at some of these interesting characteristics of the populations of underserved, uninsured. As we move to our next slide, we're going to look at multiple risk factors. So you'll see here the main three areas that we were focusing on is the minority status, low income, or low socioeconomic status, as well as their insurance status or the uninsured. And unfortunately, when you start to put those populations together, there's also subgroups that have multiple risk factors. So if you look here at the chart, you'll see that the low income group may be 21.5%, but of that, 7.7% actually have multiple risk factors. So they have both low income issues as well as lack of insurance. So when you put all this together and you consider the fact that there's multiple disparities, you can also recognize how difficult it is for these individuals to actually gain access to care. In the U.S., overlapping risk factors are associated with disparities in access to health care. Reasons for disparities in access to health care are certainly many, but they do include some of the following, both on this slide and the next. So lack of insurance coverage, lack of regular source of care. So for those individuals who end up going to the emergency department rather than seeing a primary care physician or even regular visits to a clinic. Lack of financial resources. There are some legal barriers, structural barriers. Healthcare finance system tends to put barriers in place because they say you need to pay up front in an urgent care if you don't have insurance rather than being able to have payments. So if you can't afford to pay up front, then you need to go to the emergency department. Scarcities of providers. There are very few providers who actually service our Medicaid population. Offices are only required to service a certain percentage and still receive funding, so that is an issue. Linguistic barriers, so if I want to go somewhere close to my home, but they actually don't have anyone that speaks my language to help me with healthcare decisions. Then we also have the health literacy, lack of diversity in healthcare workforce, and then age issues. So we now know that there are many reasons for disparities in access. Up here, I want to make a strong point, and that is that poverty robs human beings of their most basic rights. It keeps people hungry, it deprives them from medical care, clean water, and education, and certainly opportunity to work, and often results in a sense of powerlessness, hopelessness, and inequality. As we move towards the idea of resolving disparities, let's consider some of the service agencies that are helpful in making that happen. So from the federal level, we talked earlier about Medicare, Medicaid. There's also Social Security, and that's primarily for those with disabilities, physical and mental. We talked about Medicaid being for the poor and Medicare being for the elderly. At the state level, we have the CHIP program, we have PA Career Link, which has multiple services listed. We have the PA Department of Labor and Industry, that's basically unemployment. And then in the local area, think of your local area, what resources are available to your population. So in the Lancaster County area, Water Street Rescue Mission is a huge resource for those who are underserved, as well as many local food banks. So as you prepare to wrap up week number 4, finish up your wiki projects, and then move towards your Resolving Disparities paper in week 5, think of all the different resources that are available that you can use to make an impact on resolving the disparities.